How can I win? Well, this is a one-sided talk, remember. I've been put up for this, so I'll provoke you again. But why might somebody prefer collagenase for suitable chords? Remember, suitable chords. Well, familiar and comfortable with this particular technique, I became involved in this through FESH, actually, and we had to devise a safe training program for this drug. Because the trouble is, you see, I think, giving Zeopex is actually very easy. Because you find the needle, you find the cord, you put it in. It's actually pretty easy. There's no learning curve to it. The only danger is you don't stick the needle in too deep and puncture someone's flexor tendon. And so we had a little training program to just try and make the drug safe, because it's actually quite easy. Whereas, in fact, I think needle fasciotomy, credit to you, Paul, I think it's actually quite a difficult technique to learn. I think it needs a lot of experience. There's a long learning curve. It takes years of confident use before you get good at it. Zeopex, anyone can do it, actually, as long as you don't go too deep. We had the POINT-X study, which is a pan-European study, and the results are actually pretty impressive. And this was published actually early this year. That was the E publication, 2014. Something that's quite interesting is the drug still keeps working, and the improvement continued. I think a lot of people have seen that the improvement with Zeopex, whatever the half-life is, I think it's just a couple of hours, isn't it, Harry? It's not, Larry, it's not long, but the drug keeps working. I think there's some different change going on. And there's a very quick recovery. I've done quite a few of these injections so far, and these are in selected patients, as I sort of talked about in the last talk, and pretty reasonable results, really. And these are my results as from last week, as it happens. So 94% full correction at the MP joint, 72% at the PIP joint. We've extended the indication to complex cords as well, running across two joints or a notatory cord. Now, here's something else, in my opinion at least, using collagenase is a little bit more elegant. There's Paul there with his hydraulic jackhammer, puncturing away these cords like this until it punctures. Whereas I come along with my, and you just inject the drug, and the drug does the job for me. It's very elegant, it's very smooth, and there's Paul sweating away with his jackhammer. He's been there. So I think there is a difference in the elegance of these two techniques. And I think patients probably would choose not the man with the jackhammer. I do think it's easier to do, and I think there's a quicker learning curve, and I think it's less surgeon dependent. And it's quite telling how few surgeons actually do needle fasciotomy. I think I ought to do more. Those Twigs, where I get tempted into injecting collagenase, I ought to be actually using a needle, but I need to be taught properly how to do it. I think it'd be much harder just to go and do that, whereas you just stick in some collagenase, and it's easy. You can't miss. So I think it is easier, and I think surgeons have taken up collagenase in greater numbers than they've taken up needle. Now, whether that's because of the SOBI marketing and all the rest of it, it probably, I don't know, maybe it is. We're all sort of aware of that, but equally it is a harder thing to learn. I think it's perhaps quicker to set up. Once you've got the drug, the nurse gets out the fridge, you inject it, a day or two later you pull it straight. It's quite quick to set up for needle fasciotomy, at least for me, takes quite a while. I'm sure when you've got your system up and running, it's a bit more efficient. But it's quite quick and easy to do a collagenase injection. Patient opinion, nearly half of my patients have been self-funded, and they'll pay €2,000 for their event. Patients would travel and seek you out. And I think patients, if you sort of talk to them, there's no science to this, there is some sort of concept that with the drug, you're actually removing disease, you're taking away the cancer, something's coming away from their hand, a surgical drug, if you like. These are our figures. Again, these are up to date from last week, but we've surveyed them over a 4-year period, and you can see that about 70% of patients are satisfied with collagenase. Interestingly, this will be for another day, the satisfaction rates are falling over time as recurrence starts to kick in. Will they have it again? Well, most people would, not all, but most people will have it again. And again, that willingness, we've got curves over time showing that they're less willing over time as the disease comes back. We had the opportunity to ask our patients who've had surgery, would they prefer it? And of the 78 who have had surgery, you can see that 70% would have the drug again. I think it's a bit more versatile. The drug does the dissection for you. Here's the thing, if you look at your patients when you inject Zeopex, it's not just the bit you inject. You inject in quite a small area, but when you come back the next day, I'm always staggered about how much of the cord has gone. I'm even more staggered by people who have bruising right up their arm and in their armpit and even in their chest. So the drug isn't just dissolving collagen, I don't think. I think it must be provoking some other chemical reactions at the site of injection. And I seem to have noticed that around the PIP joint in particular, where an operation can take an hour and it never goes straight. With Zeopex, the finger very often will go pretty straight. It's not just where you inject it. I think Zeopex, it goes a bit further. If you look at this little matrix here, Zeopex, PNF doesn't remove collagen or cells. Collagenase does remove collagen, although not the cells. And I think the reason we get high recurrence, both me and Paul, because we do, is I think we're leaving those cells that we heard about this morning, they're still left behind. We talked about twigs and logs. I think as the cords get thicker and longer and more broader, I'm not sure I would be able to manage those with a needle, quite frankly. I don't know if anyone can. I can't. Those big, fat, thick ones. Whereas a twig, of course, a needle's much, much easier and probably better. So I think it is more versatile overall. I think the PIP joint is difficult with a needle because you're worried about the nerve unless you're an expert, whereas with collagenase, it's dead safe. You just inject the cord, and as long as you go outwards away from the tendon, you're going to be just fine, and there's never been an important nerve injury. And I think it's, for recurrent disease, it's effective, although beware it under a skin graft. I think that's a bit dangerous. And is there less recurrence? I don't know, actually, is the answer. I'm not sure. Again, we're comparing apples with oranges here. I think different size cords will have a different likelihood to recur. But perhaps because we're removing a bit of disease as well, it's less likely to recur, but I don't know that. If you do operate after Zeopex, I've done 6 operations now. One of them actually was a little bit gummy and gooey, but otherwise it seemed very easy to do. So there are reasons where I think there are some advantages to collagenase for certain patients, but I'm cognizant of a learning curve, and I think if you're good at PNF, I get it. I also think that with the logs rather than the twigs, I think Zeopex has some advantage. Thank you.